In October of 2019, The Lancet published an essay titled Touch, the First Language. The piece was authored by editor-in-chief of The Lancet, Dr. Richard Horton. In the essay, Dr. Horton dives into the need for touch between the physician and a patient in the exam room. This all comes as more and more clinical time is spent doing work akin to data entry. Dr. Horton wrote that touch, expressed through the physical exam, communicates comfort and concern. It encourages cooperation, and it's time to bring touch back into medicine.
We're working in the most inspiring, visionary, wonderful of professions. We should be excited every single day we go to work about the privilege that we have to do medicine. There's nothing better in life than a career in medicine. I still believe that, but a lot of doctors don't believe that. A lot of doctors believe they get to their 50s and they think, I don't want to do this anymore.
But even if everyone agreed that touch and the physical exam do need to be more prominent once again, that change would need to start at the top.
This has to come from the top. It has to be the leadership of medicine in every setting, and it has to come from the bottom, by which I mean the values in medical school and the way we assess doctors through their careers.
This is Medicine in the Machine, an information and conversational podcast from Medscape about how technology is impacting medicine now and how it will in the future. I'm a producer on the show, Nick Andrews. Without further delay, please welcome Dr. Abraham Verghese and now, Dr. Eric Topol.
Welcome, Dr. Richard Horton, the editor-in-chief of The Lancet, and Abraham and I are going to explore with him his views about this whole combination of medicine and the AI world, and I'm sure we'll get well beyond that. So Richard, welcome.
Thank you. It's great to join you.
You know, it's amazing to me because we go back at least 20 years, but you've been editor of The Lancet for 25 years now. How have you survived that?
It is an exercise in survival. That's exactly the right word. I know. I mean, people say you should only do a job for 5 years and then move on. Somehow that little rule of life seems to pass me by and I'm still stuck here. But maybe that's a testament to the fact that The Lancet is a pretty interesting place to be still.
And Abraham and I, you caught our eye and interest in your October essay, Touch, the First Language. And I want to turn it over to Abraham because this is some topic that he's been very active about in writing, and maybe you kind of introduce that.
Hi, Abraham.
Richard, it's great to have you on the show and get to see you like this. I've been a big admirer of your writing, not just editorials in The Lancet, but in so many other venues and your books. So thank you so much for joining us.
And you too.
As I said, as Eric said, the piece you wrote was just quite touching. It was very personal, and it was really a moment that gave us pause. I mean, are we basically coming to this watershed moment in medicine where all that is nostalgia, or is this something that we need to recapture? Of course, I think we all have different views on that, and I would love to have you expound on that some, if you would.
Sure. Well, I remember, as Eric said, I've been at The Lancet many decades, but I started off as a medical student in 1980, and the years as a medical student were all about some very fundamental clinical skills, taking a history and the basics of a physical examination. And we used to write pages and pages and pages on the history and physical examination. I mean, we would draw pictures of the size and the shape and the layout of the rooms of the person's home and how far they were from the shops. And I mean, it was like, you know, it was the most detailed kind of social history that you would have as a context for whatever their presenting complaint was. And similarly with physical examination, you would examine every cranial nerve down to the very, very last neuron, it felt like. And it was a fantastic skill base to have going into the practice of medicine. Roll forward 25 years, and I found myself on the other side of the desk, so to speak. And last year, I had a diagnosis of stage 3B melanoma, for which I had some pretty extensive surgery. And during the course of this whole process, I initially saw an absolutely wonderful plastic surgeon, and then was handed over to the oncologist. And I have absolutely nothing but good things to say about the National Health Service and the way the mechanics of the care was dealt with. But through this whole process, I found it utterly remarkable. Not once did anybody ever do a physical examination. The site of the melanoma was here. And so perhaps nobody thought that I had a heart or a lung or an abdomen that needed examining, but nobody did anyway. I had all kinds of MRIs and CTs and PET CTs and ultrasounds, but the idea that anybody was going to touch me with their hands to actually examine my chest or any other part of me was clearly not going to happen. Not only that, nobody ever took a full history of me either. And this was all going into a 7-hour surgical procedure, and then being in hospital for a week. And honestly, at the end of all that, nobody would have had a clue who I was. I mean, I was the person who presented with this particular diagnosis, and they did a great job. But in terms of me as a human being or as an individual who had to have a place to go back to live and a life, there was nothing about that. And then I got handed over, but I thought, well, you know what, surgeons, now I get handed over to the oncologist, and it's going to be a different thing. And I see this absolutely wonderful oncologist, fantastic, technically. But I go in and I sit down. She never looks at me. She stares at the computer, and she's looking at my lab tests or the latest scan results, and she asks me how I am while she's looking at these, and I say, I'm great. And she says, great. And she says, and your lab results are fine, and your scan was fine. So we'll see you in a month, and here's your next prescription. So I say, great, and thanks. And if the consultation lasts 2 minutes, that's quite a long consultation. So the whole process of this highly technical medicine with immunotherapy and all the things that are on offer, which is absolutely fabulous. It's, I'm here, I'm happy, I'm strong, I'm well, but I feel like this system of medicine that we've created has become the most depersonalized, dehumanized, automatic system, which has lost its humanity completely. And I feel profoundly sad that the profession that I love and have nurtured throughout my life seems to have taken this turn away from humanity. And I'm trying to understand what's gone wrong.
I think it's helpful to parse your article, because I think you're not exactly saying that you think we're making major diagnostic errors by not examining, although I think we may well be doing that a lot. You're really bemoaning something more fundamental in the relationship that has gone missing because of the absence of the physical exam. You're speaking of the exam and the history as being a ritual that in that ritual and in its execution, there was a bond that took place. And if I hear this right, you're really bemoaning the absence of that ritual and that connection. Would that be fair to say?
Well, Abraham, you used the word relationship, and I think I would reply back, what relationship? The relationship doesn't exist. You know, I think that there really is something deeply powerful about the therapeutic relationship that a patient can have, should have, with their physician or with the nurse, the specialist nurse that one might be seeing also, whoever the healthcare provider is. And I certainly remember, as I'm sure you do, experiences when we were literally living in hospital where you had deep connections with the patients who, I mean, you've written about that, I know, in your work. Deep connections with the patients who one was seeing, where your life became entwined with their life in the context of the clinic. And that affected you and you affected them, and that was all part of the therapy, or part of the treatment, of the management, of the support that you were giving to the person in their particular predicament. And the technical progress of medicine, which has been so phenomenal in the past 20 to 30 years, I certainly pay tribute to. But the result of that is that those very fundamental skills that are about building that therapeutic relationship appear to have been lost. And I've checked with colleagues and friends to see whether this is an N of one experience that I'm describing, and I don't believe it is. I think this is an experience that that might be amplified across medicine in the Western world, and I think that's a serious reason for concern, because medicine is not just about, as this is such a cliche, but as the way I was taught, is not just about the disease, it's about the dis-ease of the patient. And the medicine that we're offering needs to attend to the dis-ease of the patient as much as the disease. And I don't think that we perhaps are thinking in that way as much as we should.
Well, I couldn't agree more with you, Richard. I mean, it's one thing to read your essay, but another to get your personal account like this. I mean, it's kind of gut-wrenching for a global leader in medicine to have experienced this firsthand. You know, in that essay, you talked about touch, building trust, reassurance, sense of communion. You quoted Margaret Atwood, touch comes before sight, before speech. It is the first language and the last, and it always tells the truth. So that humanity has been lost. I couldn't agree more with you. I think Abraham and I, one of the reasons we got this podcast going is because we think this is a pervasive problem. It's tied into the global epidemic of burnout that you have written about in the Lancet.
Absolutely.
And we need to get this back. We need to get back the touch and the trust and the presence and all these things. So do you have any ideas of how that could happen?
That's a really good question. I mean, and it's very hard for a patient to take control of a consultation, to be able to do that on a one-to-one basis, for example. I mean, if I just, you know, I'm the one who has to ask for would you mind examining me? I mean, in order to get touch going so that I feel that there's a connection, I actually have to ask for that. And I feel nervous when I ask for that, and yet I'm a doctor, and you know, I know how the system works. Can you imagine what it's like for somebody who doesn't understand how the system works? It must be frightening. Well, I think the whole in terms of changing, it has to begin at medical school, and I have a daughter who is in her first year at medical school now. And I hope that as she is being exposed to patients and learning these fundamental skills, I hope that this emphasis on the humanity of medicine, the notion of a personal physician, that you are, you know, this is not just a list of to-dos after the ward round. This is about developing a set of personal skills which are about rehumanizing the scientific medicine that we've created today. And that has to begin at medical school, and then it has to be reinforced throughout the culture of practice. And again, I'm not sure that we do that at all well. The metrics that we've instituted that measure the success of medicine today do not take account of these humanizing dimensions of patient care, partly because there might not be an index or a metric or a number, a quantity that we can apply to that. And we've created a medicine that's driven by metrics and quantification. And that should also be a concern to us, that we should be thinking about the continuous professional development of a physician, the support for that physician throughout their lifetime, in a way that recognizes and rewards their professionalism, not just as a scientific doctor, but their professionalism as a personal doctor, as somebody who's there side by side the patient, sharing this journey with the patient and being their partner in that journey. And that's a difficult thing to put a number by. I will agree, but it's something that we should take more seriously.
We'll be right back with Richard Horton and Abraham Verghese in Medicine and the Machine podcast.
You can read the transcript from this podcast and find more Medicine and the Machine episodes at medscape.com/machine. Medscape news, features, clinical tools, and education are available for free. Stay on the pulse of medicine. Visit medscape.com.
Richard, if I may, I'm so happy that you're well and that everything has worked.
Thank you.
I'm going to push back a little bit just for the sake of being the devil's advocate, because we're all too much on the same page in many ways. But first of all, I think a patient would say, "What took you so long?" This is what we've been experiencing for so many years. This is hardly news for a patient. And the second point of view that I want to advocate for is that of our young physicians. Your daughter, for example, I have the pleasure of teaching medical students in the first 2 years, and they're so excited to pick up the ophthalmoscope and the stethoscope and all the things we teach them.
Yeah.
And then when they come to the wards, they experience a crushing disappointment that the currency on the wards does not revolve around these things.
Right.
It revolves around the screen,
Yes.
the computer. And that's our doing. That's not their doing, is the pushback you're going to hear.
Yes.
So my question is, you're in a wonderful position as a spokesperson for medicine. I think we have to be realistic. I love that you use touch in the title of your article. Realistically, given the pressures of time and reimbursement, how easily can we actually demand this of our junior physicians without putting structures in place that, as you say, reward that? And I really like that idea of rewarding that. I'd like you to sort of think about that a bit in terms of the practicality, what we might do tomorrow, for example.
No, I mean, you're absolutely right to say, where have you been? And it's true. This is not something that I had seen, and it was a surprise, even a shock. But I do think that something has changed in the last generation. I really do. I think that the technology of medicine has advanced so rapidly that, as you say, because the pressures that young doctors are under today, that means that some of those, the time that you used to have to sit on the edge of a patient's bed and spend an hour just shooting the breeze about their life, who has that time now? I mean, it's really, really tough. So I accept that. But I think that there is a halfway point where, one of you mentioned it about burnout. Why is it that doctors have become so despondent and disillusioned and discontent about their careers? We're working in the most inspiring, visionary, wonderful of professions. We should be excited every single day we go to work about the privilege that we have to do medicine. There's nothing better in life than a career in medicine. I still believe that. But a lot of doctors don't believe that. A lot of doctors believe they get to their 50s and they think, I don't want to do this anymore. The symptoms crush me. It's destroyed me. And I need to get out before it kills me. What have we created to lead a doctor to feel like that? And part of it, I really believe that part of it is that we've lost the connection as a human being from one human being to another. And what we've become is we've become bureaucrats in a system, an administrative system, where it is the screen, it is the paperwork, it is the reimbursement, it is the pushing around of the administration of medicine, and not the thing that we went into medicine for, which was the human connection. Most doctors love people, but we've created a medicine where there's no opportunity to express that love of people anymore. It doesn't, and that has to be what we have to bring back into medicine. And that means, challenging though it is, our clinical leaders, the people who are responsible for running our clinics, our hospitals, this has to come from the top. It has to be the leadership of medicine in every setting, and it has to come from the bottom, by which I mean the values in medical school and the way we assess doctors through their careers. And I think we are talking here about igniting a revolution in the way we live and practice medicine to in a sense, revivify medicine with those fundamental values. I'm not talking about going back to a golden era of Osler. That's not what I'm talking about. I love the technology of medicine. I'm alive thanks to the technology of medicine. I owe everything to medicine, but I want medicine to be the humanistic discipline that I know it can be, because if we don't make medicine part of our humanity, then the benefits that we have given to the public through the power of our therapeutics are not going to be sustained. And so if we want sustainable improvements in health, in well-being, in the life and purpose and meaning for individuals, we have to rehumanize medicine in a way that I'm describing. And that needs to be part of the project of medicine in the 21st century, that revivification of the values of the medicine that we all love.
I want to just reaffirm everything you just said, but I also want to point out how this is such a crisis and it can't wait. That is, to think that medical students, by the time that they get into the world of medicine, things are in a really dire state right now. So the question is, and you alluded to this earlier with a 2-minute appointment, and also the hour that you might have to spend at a bedside. And so the theory is the gift of time could get us back. Now, and the other thing you touched on also, Richard, is the administrators or administrative. That is, it's the only profession that I know of where it's managed by the non-people, that is administrators rather than physicians largely. Right. But here the vignette of Geisinger that at one point was run by a physician, David Feinberg, and he had this program, I don't know if you're aware of it, where he locked the patient and doctor in the room for 40 minutes. They couldn't leave the room, even though they tried, the doctor, not so much the patient. And it led to an incredible fulfillment of both patients and doctors throughout the system. Now, they couldn't continue the system because that 40 minutes, which is about 10 times the average time actually with a patient and doctor, because it wasn't highly productive and efficient. And of course, this is part of the kind of big business, especially in the US. Perhaps, the NHS is not quite the same. It's not the same kind of incentives. But, do you think the gift of time, if there was time, that would be the foundation for this rehumanization?
Oh, absolutely. I profoundly agree with the idea of the importance of time. Being able to just sit back in your chair and put your hands together and to be able to sit with somebody and say, let's talk. You go first. Tell me, how are things? And just let the conversation roll. That takes time. And time is almost, perhaps we need to be, if we need to talk in a language that is understood by hospital and clinic management these days, then maybe we need to talk about a prescription of time. Maybe we need to, if we're going to operationalize this and we can't all have 40-minute consultations, okay, maybe we can't always have a 40-minute consultation. But you know what? I'm going to prescribe a consultation that is 40 minutes. And maybe we're not going to do it every month, but we're going to do it every 2 months or every 3 months. And you know what? We are just going to sit back and we're going to let time roll and we're going to talk. And I think that we can introduce that in a way that would be perfectly possible in a busy clinic. And again, the other thing I would say is it doesn't have to always be the doctor. The people who actually matter to me on a daily basis more than the physician are the specialist nurses. Those specialist nurses know how to navigate everything in the hospital. And if I was able to sit down with one of them for 40 minutes once a month and just sort of shoot the breeze about what's going on in life and thoughts and fears and anxieties, I've gone all dark here, then that would be enough for me. But I don't have that opportunity. So the prescription of time might be the way to actually address it.
I want to ask a question to both Eric and to you, Richard. You used the word revolution, and as it turned out, Eric has written eloquently about physicians sort of taking power back, the whole idea of physicians as a labor movement. And I know Eric has a lot of interest in that and has explored that. What is the sentiment in Britain? Because clearly here, it's not that physicians or future physicians like your daughter don't want to be with patients. Rather, it's that they are so burdened with data. The care of a patient has become so complicated that, and nothing else has given way, that it's just untenable. And I think until there is a revolution and people say this is untenable, and things like reimbursement in our country change, and the equivalent over there, nothing will really change, is my great fear. So I'd like you both to speak about that. Maybe Eric first.
Well, I had a remarkable experience, with the NHS in planning for the future, and I learned the differences, that the advantages of the single payer system, but both systems, ours and yours, Richard, in the UK, have a common problem of very limited charge. That is, physicians are not really calling the shots in any way. And I remember back to the whole doctor shortage, the strike and the young doctors in the UK, but that's kind of like what it is every day in the US in terms of dissatisfaction and having these overlords that are really not at all sympathetic to more time and the ability to do the proper history and exam, the fundamentals, not just of medicine, but also of the human essence of medicine. So, the thought is that we do need a revolution, at least here, perhaps more broadly, to take back medicine. And we lost it along the way. Too many things happen with doctors just being passive. And, activism is something that's largely been missing. You've been an activist throughout your career, Richard, on many, many topics. Sometimes, of course, that made for challenges, but that's been largely missing in the world of physicians and the medical community at large. Wouldn't you think?
Oh, absolutely. I think that doctors have lost their confidence. And I think we've lost our confidence because we've been attacked by lawyers. We've been attacked by governments who want to overregulate us. We've been attacked by the media when there's a scandal of some sort and it's blown up into some enormous systemic problem with medicine. And we have utterly failed to communicate to the public and to governments the tremendous successes that medicine delivers to the public every minute of every day up and down our respective countries. And the result is that we've become overly defensive, we're far too quiet, and we need to be much more activist in what we do. And I would point to the 19th century. The 19th century in my country, in the United Kingdom, was a century of medical activism. This was the time when science was beginning to have a huge impact on patient care. It was a time when Dickensian conditions in society were leading to powerful social reformers standing up and saying this is unacceptable. The Lancet was born in 1823 at a time when medicine was discovering its voice in society, and not just its scientific voice, but its political voice. And what I think we have lost is that political voice. We've lost our activism to take our case for what we believe in to decision makers, policy makers, political leaders. And we need to find that voice. We need to find that voice again. Unfortunately, the institutions that represent us, certainly in my country, have utterly failed to hold governments accountable for what they've done to medicine. They've been far too concerned about having their place around the table in discussions and not being activist enough in making the case for medicine. And I look at the American Medical Association, I look at the American College of Physicians, and I see much the same problem in the US. So yeah, we have had this awful situation in Britain called Brexit. And
heard of that.
I hate Brexit. However, the phrase that became the defining idea of Brexit was summed up in 3 words: take back control. And that should be those should be our words. Every doctor up and down the country should take back control of his or her profession. It's the profession we love, and we've lost it, and we need to win it back again.
Wow, that's so well said. It's hard to come with another question after that. Abraham, anything you want to add there?
I think that's just wonderful and so well said. And that's a siren call. And perhaps we're going to be in the front of this movement on both coasts.
I'll join you.
Thank you for that. I want to sort of bring us back to the really poignant message with which you started and which we started this conversation, which was your paper with its wonderful title, Touch. And that word touch keeps recurring again and again. I'll just say that, I think we in America, when we talk about the bedside exam, we focus a lot on the medical errors, the simple kinds of errors you can make when you don't do the exam, embarrassing errors, to be called by the radiologist the next day and be told that there's a strangulated hernia or a scrotal gangrene.
Yeah.
They're embarrassing.
Yes.
But I think that, there is an element to the touch that you really have honed in on. And I think it's about caring. It's about expressing your care for this individual. And I want to read, just the last end of the paragraph of your paper, if I may. You say, the impersonalization of the clinical encounter has been a severe setback for medicine. Underestimation of the importance of touch denies the universal need for physical connection and human relationships of whatever kind. Touch, expressed through physical examination, communicates comfort and concern. Touch encourages cooperation. It's time to bring back touch into medicine. I just want to salute you because I think many of us have circled around that, and you were just brave enough to come out and say it, just as you're brave enough to say we should all, lead this revolution, take back control. I'm just delighted that you were able to join us for this session.
Well, it's a real pleasure to meet you for the first time, Abraham. I've admired your work for many, many years. And it's also wonderful to reacquaint with my old friendship with Eric, which goes back several decades. And you're doing great work with this at Medscape, and lovely to talk with you both.
Well, thanks, Richard. You've inspired us, and I know you're going to do the same for all the people listening. It's great to have your voice about this really vital topic. Right now, obviously, everyone's concerned about COVID-19.
Yeah.
Eventually, we'll get through that, I'm sure, but this is the one that's going to be something that has to be addressed. It's so critical. So thank you. We hope to get back to you because, maybe there'll be a more sanguine outlook over the next several months or a year. So we hope to have another chance to visit with you at some point. Thanks very much for joining.
Thanks very much. Thanks, guys. Appreciate it.
Thank you.
Take care. Bye-bye. Bye-bye.